So, a very good morning to everyone. Good morning, good morning, good morning, and a warm welcome to all of us. We shall be starting shortly, but before we start, I would like to walk us through the agenda for today, after which I will hand over to the Executive Director for PIC, Dr. Osasoyi Dirisu, to give us the welcome address. So we'll start with her welcome address, after which we will go into a short presentation that will be given by my colleague, Mr. Akinwumi Akiola, who is the lead for the Behavioral Innovation Lab here at PIC. He'll be giving a short presentation on how we came up with the typologies or models for women advocacy coalitions, and how we then, after that, ranked the different typologies to come up with the one that is the best fit for Nigeria, for our context here in Nigeria. After that, my colleague, Ms. Emmanuel Mwala, who is the head of research, will be walking us through the methodology used for the study, as well as success indicators and some of the recommendations that we had upon completing the study. That would then segue into the panel discussion with our four panelists. Each of the panelists will have about 4 minutes for each question. We'll have 2 rounds of questions. And after the second round of questions, we will then open up the floor to the audience to ask any questions. Since we're being very conscious of time, if we are not able to get to every question from the audience, please, I'd like to encourage you just to, don't feel discouraged, drop your questions. I will do our best to make sure that those questions are answered in the follow-up to this webinar. Following the questions from the audience, we would then very quickly, in 5 minutes or less, take a general picture of everyone. So while you are under no compulsion whatsoever to keep your video on during this webinar, we would like to crave your indulgence to, at the end, just very quickly turn your video on so that we can get a group picture. And then after the group picture, we will have a vote of thanks, and I will follow up with next steps. So at this point, I don't know whether we have Dr. Dirisu. Has she joined?
Yeah, good morning, Tom. Yes, I'm here.
Over to you, Ma. You have the floor.
Good morning, everyone. Thank you so much for joining. Sorry, I have some issues with my camera. Thank you so much for joining this webinar. I'm not going to take so much of your time because we have quite a lot of colleagues who are here to do justice to the topic. But I want to especially thank our esteemed panelists who have taken time to join us this morning. This is a very important topic. Over the weekend, I think there was this conversation about a woman who died of, I think, preeclampsia. She was in labor for a long time. She had delivered with a TBA close to the house the previous couple of years. So thinking this would be another normal pregnancy, that was her thinking. Unfortunately, very complex story, but couldn't get the help she needed and she died. And these are conversations that we have to have every other day in Nigeria. So prioritizing women's health and reflecting on how to advocate better, at different levels for improved quality of care, but then also improved end-to-end conversations around the quality of healthcare workers, production of health workers, ensuring that our facilities are adequately staffed, and all the different infrastructural bottlenecks all the delays, either from seeking care or delays from getting the right kind of care when they actually seek the care, or whatever decision-making conversations need to happen around access to care. So this is another opportunity to just reflect again and discuss from against the backdrop of this work we did on just looking at what sort of models would work for women's health advocacy, and this was supported by the Gates Foundation. So thank you so much again. Thank you to everyone who has joined. Thank you also to our esteemed panelists, and we really look forward to an insightful conversation. Thank you, and over.
Thank you so much, man. That was very insightful and also very quick, but covered all the basics. So I believe Dr. Dirisu, our executive director, has very, very laid the foundation for the conversations that would be happening here today very, very appropriately. Next, we will be taking a short presentation from Akinwumi Akinola. But while he's still getting ready to come up, I would like to lay a little bit of a background or foundation, if you will, because I realize that we have a very mixed audience here. So if you are already an expert in the field and a practicing women's health advocate, please bear with me while I give a little bit of context and background for those who may not be as familiar. So I guess the urgent question on the minds of anybody who isn't as familiar with women's health advocacy, or why the need for women's health advocacy. I believe that Dr. Dirisu had kind of touched on that already with the introduction. But the key issue here is that women's health in Nigeria is still a very big challenge. And to put it in context, Nigeria makes up less than 33% of the global population, but we contribute 20% of the the burden of maternal deaths world over. As if that is not enough, um, out of every 22% of 22 women in Nigeria who are pregnant, at least one of them would die of pregnancy-related causes. This is as compared to one in almost 5,000 in more developed countries. So that we can see that we are not at all where we need to be. In fact, some are questioning whether we would be able to meet up with our 2030 targets for the SDGs, and it doesn't look likely at this point, given where the numbers are at. And so what women's health advocates are doing is to try and change these trends by advocating at every level, raising awareness at community level, lobbying decision makers at state and national level. And so wherever you are, whatever you are doing, whether you are in your clinic, your office, in the community, talking to people about family planning, talking to people about their risk for hypertension in pregnancy, lobbying decision makers to include budget lines to fund women's health, lobbying decision makers to make sure that after the budget lines are included, the money is released. Wherever you fall within this spectrum, you are an advocate. So, what PIC tried to do was, yes, we know that all of this good work is happening all across Nigeria. The problem, though, is that a lot of this work is fragmented. So while people are working very hard, they don't necessarily get the visibility that they need to get to the ears of the key decision makers who can help. And of course, you know that if you don't have visibility, you're also very unlikely to have the kind of impact that is necessary to achieve your objectives. So, having laid this background, for those who may not be as familiar with the topic, I will now hand over to my colleague to take us through what we did in designing, ranking, and coming up with the best fit advocacy coalition in Nigeria. Over to you, Akin. Akin, you will have to unmute yourself. Okay.
Okay,
Go
good
ahead.
morning, everyone. Can you confirm if you can see the screen? My
Yes, we can hear
slideshow.
you and we can see the screen. Yes, please go ahead.
Okay, thank you, everyone. Thank you, Dr. Som, and it's a pleasure to be here. Thank you for having me. I'll speak briefly to what we did in Policy Innovation Center around centering the problem. And as many of us might know, um, we have a philosophy of work, particularly using behavioral insight and human-centered approach to solve problems. It's a five-step process. For this work, we were designed in terms of testing and evaluation. Can you still hear me?
Yes, we can, loud and clear.
Oh, okay. So I will just walk through what we did specifically. Suffice to say that we had first undergone some literature review, just combing the literature, of course, after all the conceptual definitions around what the challenges are. I'm sure Dr. Suma has provided some little context around some peculiar challenges around having a joint advocacy platform or coalition for women's health, part of which is, the siloed work and having a common front with government and all of that. And so after all of that problematizing, the emphasis of what I want to present is on the co-creation phase, which is like designing the advocacy model that would work contextually in our setting. Suffice to say that we have done some, checks, some background literature reviews, and some data collection work speaking to the stakeholders in the field. And so for the co-creation, advocacy and health field, specifically people who work around women's health and advocacy. And we started with what you call plotting, which is to really get them to imagine what the features of a successful women's health advocacy coalition should be. And people bear their mind. We came together to identify like 25 attributes of what a contextually relevant and a successful women's health coalition should be for Nigeria. And so just having that line list was not sufficient. We needed to cluster them into what you call affinity maps. What are the similar ones we needed to put together and identify major clusters? We came up with 8 clusters. So we had 8 cluster heads, just based on that activity. But we knew that all the attributes or all the essential features identified would not bear or carry the same weight. So it was important for us to assign weights, to these attributes or these features. And so we did what you call the Moscow matrix, just to assign weights to all of the 8 attributes based on whether they are a must-have, they should have, they are a could-have, or you can want to categorize them as you won't have them, which means that you can do without them. And so we came up with that framework that helps us to identify, and this was a Likert weighting on a 4-point Likert weighting from 4 to 1, just to identify what weight should be assigned to each of these attributes, each of these 8 attributes. And then based off that, I also needed to emphasize that all of these decisions were made by consensus. So it wasn't just subjective, in the realm of, or in the sense of the experts' decisions. We went further to prioritize, because don't forget I had said that we had identified the different patterns and typologies of advocacy models from literature, both internally within the region in Africa and even externally globally. And we came up with 5 typologies. So we needed to prioritize these typologies and score them based on the attributes that we think that the stakeholders have come together to decide that these are the attributes that will make for a successful women's health joint advocacy coalition. And so what we did in this 4th phase was to prioritize the advocacy model as types which were the most viable ones we needed to improve on. And so having these prototypes, we needed to do some level of deep dive wherein we broke out into sessions just for different groups to ideate around 4 domains, namely the tactics of how the coalition should be operationalized, the policy and the leadership and governance frameworks around it, then the funding as well as the structure. And typically, this is the workflow of what we did in the co-creation of. I'll just do a visual run through of what the entire process looks like. And so you can see here, this is what you call the affinity map. And what we have done is just to cluster them into the 8 attributes. You can see that we clustered most of the things that are under each of these headers actually can fit under the header, and that's what we just did. And these 8 attributes were clustered these 8 attributes were clustered based on the different kind of attributes that could fit under them, so to speak. And then we have what you call the Moscow matrix, which is what I just explained, having a like cat within to them. Apparently, when we did the conversation as a dialogue, most of the attributes were categorized into must have. In other words, they considered it essentials and non-negotiable. So you see these attributes that are clustered into must have: partnership and collaboration, clear purpose and vision, access to decision makers and influencers. Then leadership and governance, sustainability, and resource mobilization were considered the most essential. And so they carried a weight of 4, and we did that across all the LICAT. And then in terms of prioritization of the advocacy models, so like I mentioned, from what we had discovered from the literature and the ideation session with the stakeholders, these 5 typologies were identified. First is a CSO/NGO-led platform. Then we have a model that is government-led, or what you call multi-sectoral. You have the government-embedded model, and then the private sector-led, as well as the community-led. And so what we did in this prioritization matrix is to identify or layer all the 8 attributes into layer them and score them against what the stakeholders think about whether these attributes were present in each of the typologies or each of the model. And based on that, we had another like a scale of 3 to 1, 3 being high, which means that it is present in this type of model. Medium means it's here and there. There is sometimes there, sometimes not there, and low being that it is absent. And so what we did in this exercise is to base on the high, low, and medium, and then multiply it into how we have classified the importance and the weighting of all of these attributes. And this is what we came up with. And so this is what the workflow looks like. In other words, when we did the prioritization, we came up with 2 most viable propositions, which is the CSO-led and the government-led typology. And then we went further to identify the weaknesses of each of these models and solution for them based on these 4 categories of errors, i.e. tactics, policy, funding, and structure. And because the findings were interwoven, we decided that it was important to blend the attributes in terms of what the functionalities and the advantages of each of the models were, and just crossbreed them to have a hybrid model. And that's what we did during the ideation session. I'll pause here for questions and then hopefully hand over to Dr. Som.
Okay, thank you very much, Akin. I think we can take the questions at the end of the panel discussion. So please, if you have any questions on Akin's presentation, go ahead and drop your questions in the comments, and we'll take note of them and address all of them at the end of the panel discussion. And I think that segues beautifully into the next presentation by my colleague, Emmanuel, where he would walk us through the methodology as well as some of the success indicators and recommendations that came out from this study. Over to you, Emmanuel. Please confirm that you can hear me. Please confirm that you can hear me.
Yeah, we can hear you.
Okay, thank you very much. Emmanuel, over to you.
Yeah, thank you, Dr. Som and team. I really appreciate the time to add my voice to this. So I'm taking us through the methodology for this study, which, of course, Dr. Osasui, our executive director, and Mr. Akin has also highlighted before now. But then we understand that if you remember the Nigerian's health sector renewal strategy in 2023 to 2026, that actually stipulated sector-wide approach, and of course, highlighting the importance of multi-sectoral dialogue. We saw the importance of resource mobilization, allocation, accountability, and most importantly, citizens' engagement. We know that that presents a very good opportunity for Women's Health Advocacy Coalition in Nigeria. So with that opportunity, we're thinking through how do we generate evidence for the design of the Women's Health Advocacy Coalition, which Akin already described, and then leveraging the lessons from this research to do that design, learning from the regional and global practices, and then thinking of the feasibility for mobilizing diverse stakeholders, including new voices and champions for women's health advocacy in Nigeria. And for the research, we used two theoretical models. First is the what we call the Advocacy Coalition model, and also the Advocacy Strategy Framework, learning from how policies emerge and how they change over time, and also the interaction of actors within the ecosystem. And then we conducted this study in three phases. In phase one, we looked at extensive literature. What does the literature say, both regional and global? And at the same time, learn what lessons can we learn from there? What are the best practices? And what is the epidemiology of women's health issues look like in Nigeria? And we put all of that together. We analyzed the programs and policies in Nigeria, and we also conducted stakeholder mapping and scoping, looking at who are the stakeholders within the ecosystem and where are they working, what are they working on, which issues are they handling, and how do we come together to speak as one voice. And when we did that, we also did short surveys and key informant interviews, learning from people who are the actual advocates, learning from community members, learning from experts at both national and subnational levels, including at community level. And then in the phase two, we conducted multi-sectoral dialogues, at national and state levels across the three states that this study was implemented, which is Lagos, Kano, and Kaduna states. And at the same time, we used the evidence we did a lot of co-creation, interacting from stakeholders, which is that same process that Aki has explained. And in the phase three, we collected evidence from phase one and phase two, and we use that to now do the design that has already been described. And in all of this, looking at the findings, now for joint Women's Health Advocacy Coalition in Nigeria, what do we expect that success looks like, especially learning from the current government policies now, which is the sector-wide approach. Of course, the first thing that we look at when we are thinking of a typical Women's Health Advocacy Coalition presently, as we designed, is multi-sectoral participation. Participation from the private sector, participation from government institutions, from the government itself, and from community members, from individuals, from activists, from media. That multi-sectoral engagement has to happen. And then it is not just that, the voices have to be amplified. Now, for the successes that have emerged from this study, how do we amplify them? The issues that this study has highlighted, how do we amplify them? And also, even the successes that are currently going to emerge from when these the typical advocacy coalitions are implemented, how do we amplify them? The people with the real issues, how do we get them to add to their voices? One of the key things that sector-wide approach has highlighted is active citizens engagement. And that is also why it is important that as these findings also speak to that, voices of citizens are also amplified. And alignment with government policies and strategies. Yes, this is also very key for us as we implement a typical Women's Health Advocacy Coalition in Nigeria. Now, aligning with the SWAP, aligning with the Nigerian Health Sector Renewal Strategy, aligning with other relevant strategies, and looking at how does this policy trickle down to not just at the national level, but at sub-national levels, at state governments, state levels, local levels, and all of that. And while doing that, it's also important that JESI is integrated, meaning that gender equity and social inclusion is well integrated. We discovered that many of these issues, advocates are not even health personnel per se, and not just that they are not health personnel per se. When they implement, JESI is minimally considered. It's not maximally considered. So meaning that going forward, we look forward to seeing efforts, successes, and learning how gender and social inclusion, people with who do not have voice, vulnerable populations, women themselves need to be speaking for themselves at this time. They need to be the advocates with pregnant women and all of that. So we need to take this into consideration, and that is what success anticipates when it is well implemented. Now, part of the work that, from the work that we did, we also discovered that there is paucity of human resources for health. Of course, we know Japa syndrome also hits the country, while the country is also working hard to beef up that gap. It's also obvious that many advocates have also left the country, exited. And while those who are still within may not be very knowledgeable about skills, techniques to conducting women's health advocacy in Nigeria, it's also possible, it's also important that we optimize the available human resources, and where possible, see how we leverage the existing government policies to improve the performance of the available HRH. And then accountability is key, accountability and transparency. For coalitions, a typical coalition that will be implemented in Nigeria, is important that during the formation or while we are strengthening existing ones, we look at the formation. How are they formed? How do they function? What is their leadership like? What is the makeup like? And how do they, what is the reporting line like? And all of those stuff to ensure that they are transparent enough to encourage sustainability as well. And we look forward to seeing that a typical women's health coalition in Advocacy Coalition in Nigeria is encouraging resource mobilization, especially this time that we know that funding is dwindling. The largest funder for women's health in Nigeria has just exited. But then, do we stop there? The answer is no. So this is also a time, and this finding even came at a time when the funder, USAID, for example, was still very active here. But then people were already skeptical, thinking through, assuming these funders exist, how do we manage to mobilize resources that will fund women's health advocacy activities in Nigeria? So it's important we begin to think through, how do we harness resources? How do we ensure that budgets are enough and can carry the weight of the activities that are required to advance women's health advocacy initiatives in Nigeria? And then again, for available resources, how do we optimize it? So these are some of the conversations that I already imagined. And very importantly, improving policy environments is also key. Now, it's one thing to have policies on ground, like we already have them right now in Nigeria, but it's also another thing to ensure that they are implemented and followed through. They are also evaluated, making sure that the activity, not just that activities are implemented, but that the objectives are also met. Thinking through one objective, one plan, and one M&E. So it's important that that is also them, and not just at the national level, and not just talking about the sector-wide approach that we already have to do that. It's also about the current structures that are available, like RAMCA. How do we ensure that RAMCA is performing maximally, and ensuring that everyone who should add their voice to RAMCA or leverage RAMCA to advance women's health advocacy does that. Then, while implementing women's health advocacy initiatives in Nigeria, it's important to ensure that it is culturally sensitive. What works in Sokoto may not work in Kebbi. What works in the north may not work in the south. So while we learn lessons across the states, so we need to use those lessons. We need to contextualize the issues, not just about having a prototype of advocacy models or issues that we can implement across board. While that may be implementable, it may not also speak or resolve the issues that are prevalent within the states. So advocacy, a typical women's health advocacy coalition has to be culturally sensitive and sensitive to the issues that the people have. And of course, the last but not the least is the increased private sector participation, especially now that we are looking for money as a country to fund the health systems. Now, how do we harness the resources from the private sector? How do we get them to start driving some of the issues if they have not started? We know that the PSHAN, the Coalition for Private Sector Coalition, is also working hard to harness resources from the private sector. But evidence is currently showing that a large proportion of the private sector is untapped. So the question now is, part of the success that we expect that a typical women's health advocacy coalition typology should do is to ensure that all stakeholders are on board, including this private sector. Yeah, thank you. And over.
Thank you so very much, Mr. Emmanuel. He has very beautifully laid the background for the panel discussion, which we will be jumping into right now. We are honored today to have our esteemed panelists here joining from all over Nigeria. And first on our list is Mr. Abiodun Ajayi, who is the Executive Director, Public Health Sustainable Advocacy Initiative. You're very welcome, sir. Next, we have pharmacist Maimuna Mohammed, who is here wearing two hats, one as the co-chair for the Kano State-led accountability mechanism, as well as the CEO of the Society for Women's Development and Empowerment Nigeria, SWODEN. Third, we have Dr. Ejike Oji, also wearing many hats. But I think most relevant to what we are doing here today is the hat he wears as the chairman of the Association for the Advancement of Family Planning. You're welcome, sir. And last but most definitely not the least is Mrs. Chinyere Mma Ogbonna, who is a deputy director at the Federal Ministry of Health and the former head of Division of Health Promotion, Federal Ministry of Health. You are all welcome, sirs and ma'as. So without wasting any more time, we will jump right into the questions for today. But first, a few housekeeping details. Each of you will have one question in the first round, and would like to plead with you to please try and answer within 4 minutes and no more, because we are cognizant of people's time, today being Monday. So I will start with you, Mrs. Ogbonna. Please confirm that you can hear me.
Thank you, Doctor.
Okay, so given what my colleagues have earlier presented, Mr. Akinwumi talked about how the government-led coalition came out as one of the top after the ranking had happened. And we know that RAMCA is a typical example of a government-led women's health advocacy coalition. For the sake of those who may not know, RAMCA simply stands for Reproductive, Maternal, Newborn, Child, Adolescent, and I think Elder Health as well. Can you please tell us, Ma, given that functionality seemed to be a recurring issue with RAMCA, both at subnational and especially at national level, in practical terms, what needs to happen today to lead to tangible policy changes and action beyond just dialogue in terms of RAMCA's functionality? Over to you, Ma.
Okay, Doctor, thank you very much. And I am happy that we are here this morning. You know, that's looking into this very important topic. And let me thank our presenters for giving us that wonderful background. They're most welcome, and I'm also further excited being here. And also, you know, government will love, especially when we are, you know, kind of celebrating one event or the other, such as we have today, the World Health Organization celebrated, that's the UN, celebrating celebrating World Health Day. Therefore, I am happy being in your midst. So, first and foremost, let us raise a working definition that will help us in our engagement this morning. We are now going to, let me draw an inference from UN Women 2022, Gender Equality, that is Women Rights in Review, 25 years after Beijing Conference. Though some men, they don't like hearing this Beijing Conference because it is women business. So, and further draw inference also from WHO 2021, which give us the rise to a working definition that collective action for women's health advocacy is the efforts of a group of women. That's a coordinated and sustained a group of women's action coming together both both organizations, communities, that's this facets of women coming together to achieve a common objective. This is a very, very simple definition. So I will further also go and say that this is also in line to Maputo protocols. This Maputo protocols looks towards women's right. That is women's right, a protocol of the women in African Charter and human and people's right. The women's right looks up to, it is developed in Africa. Being developed in Africa, it is for Africans. So that we now look into being an international human rights instrument established in Africa, and it was established in 2005. It looks into the rights of women as it regards health, even as it borders on family planning, as it borders on having a good medical and right to, that is for abortion, that is medical abortion. There is difference between abortion, unauthorized abortion, and medical abortion. Some inevitable that is conditions. Under this background, that's having introduced this background or coming from this background, I will now look into your question where you said that is what happens today's review of that is under the RAMCAN at the national level. We can
Sorry to interrupt, ma. If you can please turn on your video, please, ma.
Okay. Yes, my video is on. Okay. My video is on.
Thank
So
you, ma.
thank you very much. So as we are now looking into the issue of RAMCA, the actions or the activities of government or the Federal Ministry of Health in line to, that is its actions towards improving women health advocacy, I will now say that government is really on the page and grips it very well. We are no longer, government is no longer on the issue of awareness creation. Rather, in action, planning, implementation, and accountability. Because when you are now saying anything relatively to government actions, it borders on that is that implementation, ensuring that there is a coordination, a coordinated activities among all the partners coming together, because it is not what one person can do. So the government now has passed the issue of just awareness creation, but has stepped up into the activities of implementation. That is the aspect of ensuring that the policies are there and they are reviewed, that they are in place, especially as it concerns RAMCA. When you hear RAMCA, we mean reproductive, maternal child, newborn child, adolescent, elderly health, and nutrition. So when we are now looking into this, government is no longer on that spot of creating awareness as it concerns women rights in or maybe that is a sexual reproductive rights of women. They have stepped ahead of that, ahead of creating awareness. That is what led to what the good of the import of SWAP, that is sector-wide approach, that leveraging on that strategy. It is a very good opportunity for government, bringing together all the partners and collaborating with all of them effectively. We can even see that these activities or maybe action of collective women's health right or women's health right advocate, women's health advocacy. It had been there in the past. If you can call back since 1960, from 60s up to 70s, it had been in place. It had been in place, but government is now coming up with a more, broader perspective of it by bringing up this ranker and ensuring that the issue of maternal death or maybe maternal mortality and infant mortality, that is from 0 age to 5, that they are being crushed in Nigeria. And that is why the current government of that is a Renewed Hope agenda came up with this SWAP initiative. Even in the past, as far back as 1929, 27, during the Aba riot, women riot, these things, they are not done in isolation. Because as you are talking about women health, you are as well talking about the collective initiative or collective activities. So I believe that my contribution this morning, in line to your question, must be, harnessed, and we now move further to make sure that we do the needful in the country. So we are no longer, the government is no longer at that awareness creation. Rather, they have gone to the stages of implementation and accountability. And in the line of this accountability, we are really working to ensure that these services gets to the people, whereby even health promotion officers, even the primary healthcare officers, they go to the roots, that is to the grassroots, to make sure that these services reaches them. Or that
Thank you
they
so much, Ma. Thank you so much, Ma. You've for that very, very detailed answer to the first question. For the sake of time, I would like to move on to the next question. We will still be coming back to you again in the second round. And so maybe you can flesh out
Thank you.
more clearly what your thoughts are regarding RAMCA functionality, both at subnational and national level. So next, I will be coming to you, Ma. Pharmacist Mohammed, please confirm that you can hear me.
Yeah, I can.
All right, Ma. So we've heard quite a bit about accountability, transparency, as a success indicator for any good women's health advocacy coalition. So that begs the question, how do we then hold our decision makers, our policy makers accountable for implementing women's health policies? And based on your vast experience in doing this as co-chair of CAMSLAM, please go ahead, Ma, the floor is yours.
Okay, thank you very much. In terms of holding the government accountable, it's not about one aspect of the populace that can do that. That's why it's now mandatory that every state in Nigeria should have a SLAM. That's the state-led accountability mechanism, which is a UN program that came, and all of us in Nigeria, we have SLAMs. And these SLAMs, we have a network of all the activities we're doing. The SLAM itself is a coalition of NGOs, the media, academia, and even the government. So in each of the SLAM, we have two co-chairs. One is the government representative, and then the other one is from the CSO. So that it is not about witch hunting, but holding them responsible to do the needful. The SLAM, especially let me tell you in Kano. In Kano, we attend their annual operational planning. We make sure that what we are bringing to that planning is what the citizens of Kano need, because we are NGOs implementing different programs at different stages in the country. targeting women's health, that's reproductive health, and also especially family planning, because our indices are very low. And then we want the government to put in money. So we do that at different platforms. One, we engage with Ministry of Health, Budget and Planning, Ministry of Finance, and also Ministry of Women Affairs. And we participate in the development of the annual plan to make sure that the information we are getting from the community is translating into their activities at the state level. And then we follow up. We do advocacy to the legislative, that's the Committee on Health, and also the chairman at the State Assembly. We do budget defense with them, because sometimes when the ministries send their budgets, they can decide to say, no, we're not going to do this. But because we are coming from outside the government as non-state actors, our voices are very clear. And because the team that we have in Kano State, more than 25 radio stations and TV stations are part of our members. So anything that comes up in one instance, it goes viral. And that's not what the government wants. So we do engagement with the legislators, and we also engage, we're members of different technical working groups to make sure that budget is allocated, and the issue is about release. When we came on board, family planning, for example, had only 10 million naira. But as of today, we have 500 million naira allocated to family planning. And the government is buying commodities with its money. So we make sure that we get data through the members of the ministries, undiluted data. How much was budgeted, how much was released, and how much and what has been done with it. Because we do spot checks. We follow them to the facilities and make sure that what they said they're doing is what is happening in the facility, because we engage with the community. That's the inclusion we are talking about. The WDCs, World Development Committees, are part of our members. And we use the village committees as part of our members. So information comes in from the ward or from the village to the ward. And also we do facility spot checks. We do exit interviews, and we ask women what is coming on board. Because of recent, we had to advocate for people with disability. For the insurance, they are not part of it. But now the government of Kano State said all of them, we allocated numbers that should be recruited into the insurance by the government to pay for them. And before, family planning was not there. Now it is part of the services that they are given because the government is buying commodities. So, and we engage with the donors here in Kano State. All the donors in Kano State, most of them are working on health. So we get some of our resources from them. And we do scorecards. At the end of each quarter, we develop scorecards for primary healthcare, Ministry of Health, SACA, each one of them that is working with women in terms of PMTCT and what are they doing. So we present the scorecard at a forum where all of them come together to say, this is our score. So this is what you have done. This is what was released, this is what was done, and these are the activities, and these are the challenges. And we follow up with them to make sure that we hold them accountable. So you can see that every state has this slum, unless states that their slums are not active. But in Kano State, as an example, I even made presentation during the family planning conference to say, if the government wants to do something, they'll say, where is the slum? Because this is the voice of the people. The women we are fighting for will not be on that level to participate in seeking for their rights. When we continue to say Jesse, 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 but it's not going to happen unless we come together as a platform advocating for the rights of these women, and also work with our donors. Donors are very critical. Sometimes they come with their mindsets. And as I mentioned earlier, it has to be culturally sensitive, religiously sensitive. If not, it will not be accepted. As my colleague said, what you can do in Kano is not what you do in Bayelsa. If you don't do it that way, people will not take it and they will shy away from it, even the women. So you now find that in Kano State now, the demand for family planning is we can't quantify it. That's why the government had to put money to buy family planning, because we had to do advocacy with UNFPA to say the government would put money. Instead of getting allocation, we are now paying for our counterpart with UNFPA so that we can get a lot of commodities to address the demand in Kano State. So it's a collective effort. And it's not about women organization. It's also about men. We're talking about gender. So it's about men, because most of the time when we come to do advocacy, we go to the governor because we're not talking about only women. So we're talking about civil society organization working in the area of health. So when he sees that all of us are talking about the same thing, it's not about women. We are not fighting for, it's not women's rights. We are talking about health, and this is what is happening. We did analysis of all the situation of the primary healthcare centers in Kano State to say this is where we have issues. Infrastructure, a lot of our service providers have retired. They are not replaced. Some are trained, they are not recruited. So it brought back to the governor to say we have to recruit a lot of health providers. If not, our health system is crumbling. And if the government doesn't take responsibility for that, then there's going to be a problem. And I like it when you talk about, when it was mentioned, the private sector. We shy away from the private sector, but they have social responsibilities. And we need data from them. We need them to have social responsibility to make sure that women that come to their facilities, as of recent that somebody died because she couldn't pay fees, that is inhuman. Because if they don't participate in the swap, then there's a problem. So our advocacy should not be only with the government. It's also with the private sector that are making money and not taking it back to the community. So these are the things that we do in Kano that makes us stand out. And to say every forum we are there, even today I'm supposed to be in the Savicom, so that we now say the women need to be heard. How can they be heard? Because of this program, I couldn't attend. I sent somebody to go there because Councilor is a household name in Kano. If you don't put us there, we make noise. So this is what I want to share with my fellow
Thank
colleagues
you
because the
so
time
very
is
much,
running.
Ma.
Yeah,
Thank you,
yeah.
Ma. I'm smiling because you had already stolen a little bit of the thunder from the next
Oh
question.
no, oh
Private
no, sorry, I was just
It's
carried
fine.
away.
It's fine. It's fine. I can sense the passion
Yeah,
coming
yeah,
through the screen.
yeah.
And I really want to commend you, Ma, for that, all the successes. You just casually mentioned 10 million to 500 million, like it was, just a small thing. I can't even begin to imagine the amount of work and commitment that went into making that a reality. So thank you very much, Ma. So we'll come to our next question, and I will be directing that at you, Dr. Oji, which is how can we strengthen public-private partnerships to fund and sustain women's health programs? And this is particularly important at this time. My colleague had talked about how with the major pullout of the USAID funding, we're having to look more internally and think outside the box for how we can fund these coalitions. So over to you, sir.
Yeah, thank you very much. And good morning to everybody. It's almost 12 also. What I would say here is that for public-private partnerships, we have to look at the key drivers to be able to succeed. And then also, when you're doing anything, you have to look at the people you're doing for the thing. Are you talking for me? If you are talking to me, am I on the table for you to hear my voice also? I know that mine is focused on women. How does PPP approach help women? But let's look at the key drivers of PPP first of all. Number one is to increase access to healthcare. That means expanding healthcare infrastructure, and then also making sure we upgrade our health facilities to increase access. It's also to make sure there is availability of the services across all sectors of the system. The next one is to improve healthcare quality. If we make sure that is improvement in healthcare quality by introducing new technologies and equipment, and then improving the workforce and remunerating the critical healthcare workforce for them to be empathetic in their approach to the services they offer. And then also making sure that you enhance clinical standards so that there will be standard across board. Then the other one is to expand the healthcare infrastructure, because if you don't expand it, that means you'll be missing a lot of people. And then you are saying nobody should be left behind. And then quality, quality makes people come back to the same facility. And then quality means that a lot of things are done in such a way that the patient's service given to the patient is guaranteed to be of quality, and there should be quality teams in the hospitals. And then we do know that healthcare financing, which is the main problem here, is the major issue we have. We have very poor healthcare financing in the country. And so how do we make sure that this happens properly? And then, of course, promoting innovation and research, because it's innovation and research that will be able to, especially research that will give us information on what is going on and how do we improve on it. So, but if we now go straight to say, how do we, this is on a, I would say, I said it on a broad term, but let us focus now on women. And it means that we have to increase reproductive health services access to women so that they will be able to have access to services as and when due. And then this is very, very important, because all these things I have highlighted, once the quality is improved, access improved, and then the financing is done properly, especially now the National Health Insurance Authority has been enhanced, and to make sure that we bring women in the right direction. I'll give you specific examples of some of these things. If you look at AFP is a conglomeration of different entities, and we have used our family planning conference as a rallying point, and I've been able to reach out to so many people. For me, on my own primary level, I decided I'm building a 5 million women database. I'm launching it in June. And one of the key things I'm looking at is to work with women directly, to work across all these value chains that I had mentioned. If we do this and make sure that the women are the center of, especially the accountability part of it, a lot of people have talked about accountability, but the best person to give you a bigger feedback as to what is going on is women. I would like to stop here. My time is up, and then we'll give room to further conversations. Thank you so much.
Thank you so very much, sir, for keeping to time. I sincerely appreciate that. And I particularly like the last point you made about centering women when it comes to this issue of accountability and speaking for themselves, as well as remuneration for healthcare professionals so that they can actually perform their work with some degree of empathy. We often overlook how powerful that can be when it comes to uptake of services. So thank you very much, sir, for that.
Thank you.
And with that, I will come to you next, Mr. Ajayi. Please confirm that you can hear me. Mr. Ajayi, do we have him on the line?
Yes,
Please
I can
confirm.
hear you.
Okay, great. So my next question is for you, sir, and it is, what strategies can we use to scale up advocacy coalition efforts to more states and communities, especially the rural and underserved areas? I know you have a lot of experience with this working in Lagos. So if you can speak to some of the strategies that you have employed yourself in your work in Lagos State or even elsewhere, that can be used to scale up these advocacy efforts. Over to you, sir.
Thank you so much, Mrs. Sima, for reaching out. And I want to say a very big thank you to PIC for giving me the platform to share my thoughts. And then more importantly, to giving me the platform, or the rare privilege to share this platform with a mentor that I really, really respect, Dr. Oji. Thank you so much. And thank you so much, Mrs. Ajia Maimuna, for that thought. Thank you so very much. I really appreciate it. Yes, at Public Health Sustainable Advocacy Initiative, we are a women advocacy, organization based in Lagos. And then based on the question asked, I'll be sharing some of the strategies that we have used in our work in Lagos State. More importantly, in also helping to advance the well-being of women, more importantly, women in Lagos State. For us, we believe that coming together as a coalition can also help us get so many results that we all desire. And when Lagos State, PITAI was initially the Lagos Advocacy Working Group before we transmitted to Public and Sustainable Advocacy Initiative. And then in PITAI, we have diverse, community groups, individuals, community influencers, people who are venture members and volunteers of our organization, who we use periodically to also, we also use them for body tracking on women's health. We also use them to also track some of these health facilities in their local government. And then how do we come about bringing these people together? First and foremost, we do that mapping. We have to do mapping. We know who are those people in the community that has influence and that has influence. So we may have influence and we may not have influence. We may have influence and we may not have influence. And we are some of them who share who are these two components. They have the influence and the influence. So what we did was to bring them to a coalition to say, okay, leadership, leverage on your leadership. I want to also leverage on your connect. Or the district level, because Lagos also has 6 districts, which is called Ibile. We have the one that falls under Badagry, Lagos Island, Ikorodu, Ikeja, and the likes. And then we have people who are also strong at this level of Ibile. So what we did was to bring them together. We leverage on their structure. We allow them to take ownership of this advocacy. So what we now did after assembling them, also engage that we train them to be a champion. We don't just assemble them to come together and then be doing this for us. We also ensure that we train them, we build their capacity. They know what to say when they meet any of the government officials. They know what to say when they meet traditional leaders. They know what to say when they meet their own key stakeholders who they want to influence. And I'll be sharing some results with us as time goes on. And what Ajia Maimuna said earlier about bringing funding to the state. When we get funded by maybe any organization or any great organization, we ensure that we bring them on board the part of the implementation. So they may not be on the salary fee, but they are on the implementation table too. So what we do is to meet quarterly, we draft work plans together, they bring their own idea. You don't live in my community, I live in my community. And this is what women are going through. And to resolve this is an activity that we believe can work and address the issue facing women in the community. So we allow them to take ownership while we take their activities and put in our own project activities that will be submitted to our funder. So these are ways that we also help them to also build their capacity and also ensure that even when funds are not there, these people are always working. They're always going to the PAC to identify what are the gaps these people are facing. And we also share membership. We extend our hands of fellowship with the community development committees. We share our hands of partnership and collaboration with the water committees, with the local government health authorities. There are no structures in the local government that we don't work with at Women Advocacy Organization Group in Lagos. So after that, we also engage the traditional religious leaders. In Lagos State today, we have a very strong interfaith organization headed by Ajia Ashiru. Dr. Ashiru is a member of the site, and she's the chairperson of the interfaith in Lagos State. The interfaith has the traditional leaders as their members. They have religious leaders, both the Lagos State chief imam, the Lagos State council president. They are on their membership. So when we have when they started their advocacy to churches and mosques and traditional spaces, we were always engaged. We're always also, we also partnering with them to expand this knowledge with other people. And then also, more importantly, we also expand media and digital working groups. So we also have a media advocacy working group in Lagos. So if peradventure you want to meet any of these people, they are our members. As a matter of fact, they, I think, not even I think, many of these groups, the interfaith, the media groups, emanated from our own coalition. Mrs. Chioma, who is the chairman of the Lagos State Media Advocacy Working Group today, emanated from our own group. Dr. Aji Ashia, who is also the interfaith chairperson in Lagos State, also emanated from the PSI group. So we intentionally expand our scope and ensure that we give room for more people to also get involved. You may not really get involved in our own space, maybe because you don't have interest in what we do, but I'm very sure you have interest in the media. You have interest as a traditional leader or maybe a religious leader. So go and join this, and then that is how we have been able to also engage the community or leverage on strategies that have worked. And let me say this, as part of the training that we gave our champions regarding media and reporting, cases on media, engaging the stakeholders on using your social media platform. We had one of our champions, Reverend Joe, who, after our training, went ahead to report a dilapidated state of the primary health care center in Lagos State. I don't want to mention the local government bit because issues have been resolved and work has started already. Now, when the chairman team saw the report on his page, he started, levying so many allegations, threatening him, looking for every means to get him and then, maybe get him arrested. So we came on board, we intervened, and then we said, okay, instead of doing this, can we just sit on a roundtable meeting and resolve this? And when we sat with the team, with the local government chairman team, we told them this is the issue. We are not saying that we are not doing well in other areas, but we want you to please provide a good amenities for the women. If this health facility is in a dilapidated state, no women in your local government will have access to it. Can you give us a befitting healthcare center that would ensure that women don't die as a result of dilapidated healthcare facility? Provide good healthcare facilities for women so that when they come, they can have access to it. They will be free to come to the facility and get every necessary medical services that they need. As I speak to you, that dilapidated primary health care center is under renovation as I speak to you. And it was as a result of our own advocacy by one of our champions. So I think these are areas that we can also leverage upon. These people are ready to receive us, but we are not the ones. We are, some of us, let me say, some organizations don't want to work with these people, and they have this interest and the influence to also help us, reach our key stakeholders. Policy and government engagement, we have been doing that. Last year, we carried out two research on women's health advocacy, who were funded by the New Ventures Fund through Pathfinder International. So what we did was to go around all 20 local governments to identify what are the gaps in the primary health care center, what are the challenges, how can we come on board to now say that, okay, we want to work with a policy, a brief. We don't want to meet the first lady of the state by mere saying that, yes, this is not good when we don't have evidence. In 2019, our organization was the one who led to the total release of funds meant for young people in Lagos State via our scorecard, which was shared with the custody of the state. And in the history of Lagos State government in 2019, Governor Sanwo-Olu was the first person who will release that total money of 50 million naira to adolescent health and youth. So we have been using that model to work. And after we're done with our meeting, we came up with a policy, our research, we came up with an advocacy group, we came up with policy, and we completed it through the Lagos State government, through the Ministry and the economic planning and budget. When they had their budget consultation meeting across the division, were invited to submit our advocacy brief. And our advocacy brief was captured. And when we reach out again to the director in charge of statistics at the Ministry of Economic Planning, he told us, Abiodun, we love the advocacy brief that you guys shared with us. And I can assure you again that women's health budget will be considered greatly in the 2025 budget in Lagos State. So these are
Thank
areas that
you.
we
Thank you so
also.
much. For the sake of time, would like to move on to the next question, but thank you so much. So many lessons to learn. If I hear what you're saying correctly, so many of the strategies that you have used in engaging your community and expanding prioritize ownership. So the trainings, engaging the community members as champions, bringing them into the implementation phase, just very awesome ideas and strategies that I'm sure many of us listening here can borrow from. For the sake of time, I want to appeal that in this second round of questions, please try and answer the question within a minute or less. And we are pressed for time and we're already past the hour. So I want to plead with our panelists to please keep your answers to a minute or less. Thank you very much. So my next question would be to Mrs. Ogbonna. Please confirm that you can hear me, ma. Mrs. Ogbonna, ma, please confirm that
Yes,
you
I
can
can
hear
hear you. I can hear
us.
you, ma.
Okay, so my
Okay.
next question to you would be, how can digital innovations, technology, and data-driven approaches strengthen coalition advocacy for women's health? Over to you, ma, in 1 minute or less, ma, please. Thank you.
Thank you very much, ma. Thank you, doctor. I think this is employing technological tools into data collection and analysis. And one of the methods can be through real-time data collection, evidence-based advocacy. This is when you employ the tools that is in line to, having some that is technological equipment or maybe systems or strategies developed
Okay, I believe we lost Mrs. Ogbonna briefly. Are you still with us, ma? We can't hear you. Yes. Okay, ma, if you we lost you for about 5 seconds. So if you can just quickly recap what you just said. Okay, I think we lost her altogether. So while she's rejoining, I guess we can move on to the next question. So I'll come to you, Pharmacist Mohammed. My question to you is, what commitments should be made today to ensure that advocacy for women's health remains a long-term, sustainable movement and not just a short-term campaign? Over to you, ma'am.
Yeah, okay, thank you very much. What we need to do is to expand.
Oh, please,
Because
doctor, sorry. Can I come in? Sorry, it was network.
Okay, ma.
Okay.
Yes, please go ahead. Pharmacist
Okay,
Mohammed,
please. Sorry,
Mohammed,
thank
we'll
you.
come back
I
to you.
said
My
that
apologies.
okay, man. I said that when you are mentioning the innovations digitally, we are now talking about the technologies imbibed or maybe employed, such as that is when you now talk about the tools required in data collection, so, such as data collection and evidence-based women's health, collective women's health. These tools, you are now bringing in something like DHIMS platforms. When these platforms are created, that is also the evidence-based platforms we use. Then digital platforms for collection and mobilization of that's information and data. you usually talk about social media advocacy and digital campaigns. These are mediums through which we lay hands on these data. And when we collect this data, we make sure that they are being that is organized, analyzed in the proper perspectives in order to give us the, or maybe for us to leverage on it and give exact report. That is bringing in the exact report of our activities concerning women's health. Also, we use some dashboard and scorecards, as my colleague mentioned before, for that is monitoring and evaluation. These are the mediums or the that is a very good instrument. That is the ministry we lay hands on, we use in making sure that we give that is the technology imbibed into digital analysis, or maybe digital platforms are in a very proper use. Even when you talk about or you bring in import that is artificial intelligence platforms. So there are so many aspects of this data platforms, or maybe data methods we can use in analyzing the collective that's the information generated. Even when we go into social data listening, when we go into social data listening, you must imbibe that is use the technology, and you have to make sure that all these things, when we now gather them, we have to report, or maybe we have to make sure that they reach the key stakeholders, or maybe the stakeholders for policy making, bringing
Thank you.
in people together and listening to them. Thank you very much.
Thank you so much, Ma. It's good to hear that the government is actively employing all of these different strategies, digital strategies, in the good work that we're doing. So I will come back to you, Pharmacist Mohammed. Let me repeat the question again, which was, what commitments should be made today to ensure that advocacy for women's health remains a long-term movement and not just a short-term campaign? Over to you, Ma.
Okay, thank you very much. What I was trying to say was we should have different layers. It shouldn't be only the technocrats talking about it. It should be at the different layers getting commitment. A colleague of mine talked about religious leaders. They are key. Traditional leaders, they are key. Women groups, they are key. Collectively, we try to build their capacity to have a voice, so that the advocacy is not just about we that are implementing programs or we that have gone to school, but in my grandmother's village, she should be able to talk about her own needs and also hold the chairman responsible to be able to do that. We have the House of Assembly, we have, so that people can now use it to hold our politicians responsible and the leaders responsible. If we leave it at our level, there will be fatigue and we'll not be able to achieve what we want. But all groups should own it to make sure that until we get that result, we are not going to bow to any distraction from anybody. That's my own thinking. And that's what we're doing now with religious leaders. We are doing sermons at Friday mosque to talk about responsibility of men. If you go through the religious aspect of it, you are massaging their emotional you are massaging them to say that, yes, you are men, but this is what our women need from you. And this is what God says you should do for them. So any project we are doing, they now say, okay, it is our responsibility because all the books are talking about taking care of women, but where are you taking care of women right now? We are not there. So this is our own strategy now that we are using. Thank you.
Thank you so much, man. Really good points. I like how you talked about prioritizing capacity strengthening at grassroots level, very important, so that women can also advocate for themselves. So advocacy capacity strengthening for women and in women's groups, and also very important, strategically engaging men. Very, very key. Thank you, Ma. So my next question would be to you, Dr. Oji. Please confirm that you can hear me, sir.
I can hear you
Dr.
loud. Yeah.
All right. So what are the biggest policy bottlenecks preventing progress in women's health? And how, in your experience with the AAFP and possibly other coalitions, how do you think that women's health advocacy coalitions can help address these policy bottlenecks? Over to you, sir. 1
Yeah,
minute.
Thank you very much. What I would say that one of the biggest bottleneck, if you ask me, is actually is philosophical. The Nigerian leadership, both political, even in the executive arm, have not really recognized that health is a right. And then also coming down a little further, the reproductive health and rights of women, that is their right and they should be given. So, and that's one of the major bottlenecks. So whatever that we are doing, even when we have had successes in making good policies, let me give you a simple example. When we successfully advocated as an organization to make family planning as a right of women and to be given free in public sites, it was accepted and started in Nigeria very well. That one has been going on well. But the other part is to make sure that we have $3 million, eventually $4 million as a counterpart support. You see, that policy is not legislative. So it's at the whims and caprices of the minister that comes and goes. The last minister for 3 years did not release that money. And that led to family planning stockouts across the country. So if we had made it the legislative agenda from the word go, it would have been made better. Let me give you another very good example also. You know, health is not on the exclusive legislative list. So, and then all the processes of monitoring, evaluation, and then frameworks to carry out policy-related issues are domain at the Federal Ministry of Health. So they can only advocate, they don't have the power to do anything. So it makes it difficult for some of these things that are supposed to peter down to the subnationals not to go well. And then lastly, lack of results-based funding. You remember that SOML was supposed to kickstart that, but it was a very big failure. So bottlenecks of policies, not that we don't have good policies, also implementation is also a very, very difficult thing. So for us at the AFP, we focus on using the multi-sectoral approach. And like these two examples I gave to, that's how we got it done. And as we speak now, rising from our last family planning conference, we have developed an FP advocacy committee that we're going to use to talk to multi-level structures of government and even the private sector to get family planning on board. I would like to stop here. Thank you so much.
Thank you so much, sir. And I really like what you said about reproductive health for women as a right. And it sounds very much like, you know, that even at that very high level, there needs to be that, will I say, education for better understanding for our leaders to understand that this is not just, you know, women making noise as usual, but to understand that this is an inalienable right of women. So thank you very much, sir, for raising that point. So I'll come to you, Mr. Jai, with my last question before we then open up the floor to questions from the audience. Please, if you have any questions, the chat is already open. Feel free to use the question and answer section to drop your questions. Very quickly, Mr. Jai, my last question for this round will be to you. How can we move from advocacy to sustained policy action at federal and state levels? Over to you, sir.
Thank you very much, Happy. So in less than 1 minute, one of the things that we need to keep doing is to keep.
Sorry, sir, I'm not hearing you very clearly. I don't know that, is there a way to move closer to your system?
Okay, can you hear me now?
It's much better, thank you.
Okay, thank you. I said one of the first things that we need to do is to frequently engage policymakers. We must continue to engage them with our facts. Yes, even though when they don't want to listen to us, or it looks like we're not getting feedback from them, I think there is need for consistent engagement with policymakers. Let us continue to sit with them. Let us continue to share why they need to take drastic action, why they need to put more effort in women's health, programming and services in the state and at the federal level. And also, we also need to start looking at appointing policymakers or let me say government officials as women health champions. So last year, when we were on the women's health project in Lagos, we appointed some key government personnel as women's health champions. We appointed the executive secretary or permanent secretary of Lagos State Health Management Agency as one of the champions, and the special advisor to the governor, Dr. Kemi, as one of the champions. And one of the things that Dr. Kemi did for us last year, after our appointment as one of the champions, was to also help us champion the release or the approval of the memos sitting on the table of the governor. We had, at the time we came on board, it was reported to us that there are 11 memos that 11 memos sitting on the table of the governor. And these memos are women's health focused in the state. And it has not been approved. The governor has not approved it. And they were sitting on the table of the governor. So what we did was to visit Dr. Kemi. So Dr. Kemi, can you help us prioritize health, women's health? And what she did after the appointment, she sat with the governor. And out of 11, before the end of third quarter in the year 2024, we had 8 memos approved and it was released. So these are areas that we feel that it will also help us get the government on their toes to start responding to the intervention that will help create well-being for women in the state. And also too, we also must also secure support from influential figures, the first ladies, the commissioners, and traditional rulers. These are people who also have voices, and we should also understand that their voices also count. I could remember during the co-creation meeting in Abuja, we were highlighting some of the power that the traditional rulers and these government officials also carry to also help us influence our request. And lastly, too, we must continually to yes, in as much as we are having some backlashes of front and back with the legislature, we must continue to also engage them. Thank you and God bless.
Thank you so much. Thank you. So at this point, we can take questions from the audience. I can see that some questions have already been dropped in the question and answer section. Unfortunately, for the sake of time, I don't think we will be able to answer more than the 3 that we have here. Okay, I see that one is a comment, the other 2 are questions. So I will take one of these, and then I believe the second question was addressed to you, Mr. Ajayi. But let me start by answering the first one of these, which is, how can we get the manual for today's lecture? Okay, that's an easy one. We will be sharing, after this webinar, within 24 hours, we will be sharing some summary notes from today's webinar meeting. And then within 72 hours, you can expect some of the output and recordings that came out from this webinar today. So fear not. The question which is addressed to you specifically, Mr. Ajayi, is thank you, Mr. Abiodun, on your well-articulated advocacy activities in Lagos State. My concern is on the issue of media advocacy group led by Mrs. Chioma. Are you aware of the media engagement strategy for health promotion developed by the by the federal government of Nigeria to guide all media engagements, including advocacy? Over to you, sir.
Okay, so thank you very much for that question. Because I'm not in the media space, and we are not, I personally am not a member of the media advocacy working group. They are journalists. The membership of that group is that you must be a journalist, either an indigenous media person, or maybe you work with any of these media outlets in Lagos. So many of them, if you notice their membership, is either you are covering the health space of a media platform, maybe like Punch, for instance, or Guardian. But based on your question, I really do not have that private information to the document. Maybe after this meeting, I'll reach out to Mrs. Chioma to know if they are aware. And if they are, I will reach out to Mrs. Soma to know how we can connect you and Mrs. Chioma on this topic. Thank you.
Thank you very much. So with that, I believe we come to the end of this panel discussion. I would like to thank our esteemed panelists. Thank you so much for your passionate and lively and very insightful contributions on this webinar today. I would also like to express our sincere thanks on behalf of the Policy Innovation Center to our donor, without whose generous support this study and all the body of research would not have been possible. So our sincere thanks to the Gates Foundation for their generous support. Thank you all so much for making time out from your very busy schedules to be here with us today. We are very grateful to have had you and to have had your time and your contributions and your questions. Regarding next steps, like I said earlier, we'll be following up within the next day or two with summary notes from today. And within 3 days from today, certainly no more than a week, we will also be sharing recordings from this meeting with all our registered attendees. And so with that, I would like to once again thank you for your time and wish you a very great and productive rest of the week. Thank you and goodbye.
Thank you.
Thank you.